Welcome to another episode of Onc Now, the podcast where we bring you the latest insights and innovations from the world of oncology. I'm your host, Dr. Jonathan Sakia, and today I'm thrilled to be joined by Professor Ahmad Awada, a true leader in the field of oncology and editor-in-chief of our EMJ Oncology journal. Professor Awada is the head of the Oncology Department and director of the Chirec Cancer Institute in Brussels, Belgium. After completing his medical studies at the Université Libre de Bruxelles, in Belgium of course, Professor Awada went on to specialize in internal medicine and medical oncology. His career quickly focused on the clinical development of new drugs for cancer treatment, and he trained internationally at leading institutions, including the Free University in Amsterdam and the Institute for Drug Development in San Antonio, Texas. When he's not pushing the boundaries of oncology, you'll find him hiking the trails or fine-tuning his golf swing. So it's an honor to have Professor Ahmad Awada on the podcast. So over to the conversation without further ado. So, Professor, good to have you with us. Some colleagues from EMJ met you in person at the 2024 Annual Congress of the European Society of Medical Oncology, ESMO. Reflecting now on the Congress, what sessions or talks particularly excited you, and looking ahead to the next Congress, 2025, what are you most looking forward to?
Thanks for the invitation. I think there are really was an important ESMO 2024 because during this meeting there was a report in many studies changing practice for clinical oncologists. I will give some example. We cannot go
Please.
through all the example. You know, in breast cancer, in early breast cancer, in hormone receptor positive patient, which is 70% of our population. High risk population, we do not have major advances since long period of time, since tamoxifen at the beginning and aromatase inhibitor later on. So at the ESMO, we have an update of the NATALEE trial, which include ribociclib, is the CDK4/6 inhibitors in combination with endocrine therapy in stage 2 and stage 3 disease. And with a median follow-up of 4 years now, the invasive disease-free survival, the delta in favor the combination of endocrine therapy, classical endocrine therapy, and ribociclib, which is CDK4/6 inhibitor, was around 5%. Absolute benefit. And that's, for me, outstanding. That was also the case for another CDK4/6 inhibitor called abemaciclib. So clearly for hormone receptor positive, early breast cancer, high-risk population, now we have, in addition to endocrine therapy, new agent, biological agent, CDK4/6 inhibitor, which improves significantly the invasive disease-free survival. I think another important trials changing practice in breast cancer, HER2 amplify metastatic breast cancer are at risk to develop brain met. And now what is really, brain metastases are usually treated locally by surgery and or radiation, and could be also radiosurgery.
Yep.
Now with the systemic therapy we have, it's now possible to treat even active brain met, not to treat it locally, with systemic therapy, with the aim to delay surgery and mainly to delay radiation. And as you know, radiation could cause cognitive disorder and very quickly after therapy. So now for this group of patients, amplify HER2 metastatic breast cancer who are at risk to develop brain met, we have new drugs like tucatinib and more recently an antibody-drug conjugate called trastuzumab deruxtecan, which showed very nice anti-tumor activity, very nice progression-free survival, even in brain met, not locally pretreated. And that's really a major advance. And the one of the trial which illustrates this, called Destiny Breast 12, which include trastuzumab deruxtecan, which is an antibody-drug conjugate. The third study I would like to mention that in muscular-invasive bladder cancer, this group of patients is normally treated by neoadjuvant chemotherapy, followed by surgery, plus or minus radiation. And so now we added in a study called, in a study which includes durvalumab, checkpoint inhibitor in combination with chemo in the neoadjuvant setting, and we have around 35% pathological complete remission at the time of the surgery. That opens the door to have strategies which are investigated now to preserve the bladder and to keep surgery a salvage approach. That was also presented at ESMO 2024. Another study of interest presented also in locally advanced, but here cervical cancer, squamous cell carcinoma locally advanced, which the standard therapy is radiation and chemotherapy. And in one arm, in the keynote A18 study, they added to chemotherapy and radiation pembrolizumab, which is a checkpoint inhibitor, compared to the standard of care since years and years now, chemoradiation, and clearly improvement in progression-free survival and even improvement in overall survival. And finally, to finish, I think one study which also involved a checkpoint inhibitor in combination with chemotherapy, carboplatin paclitaxel, in the treatment of a rare tumor, metastatic anal cancer, and clearly adding immunotherapy to chemotherapy improved the outcome of this patient. So these studies, from my point of view, are changing practice.
Yeah, and a huge amount of encouragement for patients living with these conditions. So maybe take the opportunity to give a quick advertisement for the 2025 Congress, where it's being held, when it is, and what you're looking forward to there.
Will be next year. I am hesitating. Where will be? I think in Berlin, if I'm not wrong.
Okay, fantastic.
I think for ESMO, I would like to add something, because there are what's called clinic studies changing practice, but also there are also some important studies with promising activity which open the door to increase our armamentarium in the treatment of cancer, solid cancer. And I would like to mention very quickly. We saw 3 important early studies, phase 1 studies, which include what's called protein degrader. And so sometimes we have, molecules in cancer cells involved in the carcinogenesis process that will be difficult to target. And so this kind of what's called protein degrader could be of great help to degrade this protein important in the carcinogenesis process. I am mentioning here KRAS G12D, but also there are also protein degrader of another molecule important in the carcinogenesis process called SMARCA2. So I think protein degrader are new categories, new classes, innovative agent which could change our therapeutic strategy in the near future. A little bit also more about ADCs. We have a lot of ADCs in breast cancer, but also in many other solid tumors.
Antibody-drug conjugates.
Exactly. And, we know TDM1 in breast cancer. We know trastuzumab deruxtecan in breast cancer, lung cancer, gastric cancer. But now we have a new antibody-drug conjugate from one, mainly with a new target. The classical target in breast cancer, for example, is HER2 or TROP1. Now we have in solid tumor new target, because the antibody-drug conjugate, there are two components, a target and the payload. Payload is a chemotherapy component, and there are chemical links between the monoclonal antibody targeting a receptor and the payload. And so there are new targets like B7H3, like PDL1 is now a target for antibody to conjugate, Claudin 18.2. So to say what to say, there are new target linked to new payload or to classical payload, which showed very nice activity in many solid tumors.
Interesting. So I know that this is work you've been involved in. You co-authored a review on pharmacokinetics and pharmacodynamics of ADCs.
Exactly.
Yeah. Can you
I would like to
expand on
a
that?
very quick comment on that. So a huge number of ADCs in development in many solid tumors, particularly true in breast cancer. But it's really important to look carefully to the target, to the payload, to the pharmacokinetics, to the pharmacodynamics, and that's what we did in one of our paper in breast cancer and reported recently. Because understanding all these things and the mechanism of action of ADCs, particularly the bystander effect, because cancer in general, breast cancer in particular, is very heterogeneous disease. Some of the cancer cells express the receptor, some others not. And if we have a bystander effect, you can treat all the tumor. But if you don't have the bystander effect, you can treat only the tumor where the receptor, the target, is expressed.
Yeah, very much so. I think you and I were talking before. I've been fascinated by the recent work of conjugates and alpha emitters, but we'll leave that for another day. So your research has focused on developing new cytotoxics, molecular targeted therapy for solid tumors. How do you approach the challenge of tailoring these treatments to the individual characteristics of each tumor and the role of genetic and molecular profiling? Can you talk a little bit about that?
Yeah, I think we cannot, as oncologists today in 2024, we cannot practice medical oncology without knowing well this field, because it should be part of our, let's say, functioning and thinking. So now with the development, with the progress of, let's say, technology, biotechnology, informatics, bioinformatics, we understand better the cancer cells and what are the difference between cancer cells and normal cells. And so this understanding of the hallmark of cancers is at the basis of the development of, let's say, hallmark important in the carcinogenesis process from one side, and the development of innovative agent targeting these abnormalities, which could be membrane receptor, could be tyrosine kinase activity, could be intracellular molecular abnormalities, and even could be epigenetic modification. And so that's opens the door, what's called the new molecular targeted therapy. And so now many of our solid tumors are sequenced in order to document any gene abnormalities, mutation, deletion, gene fusion, and consequently, if we have very selective drugs developed, that could be of great importance and interest for our patients. And there are a lot of innovative agents with this approach. Now, that means we should sequence our patient, but still something expensive. We need a good interpretation. We need that to have what's called molecular tumor board in order to interpret well the abnormalities we are seeing in after tumor sequencing. And so, and from other side, we need to have the drug and the innovative agent for the patient when we have the abnormalities. Because if we sequence therapy, we sequence the tumor of a patient, we found very nice mutation. If we do not have the very good innovative agent in hand, not available, or available but not reimbursed, that's really a major frustration for the patient. So, in summary, this is a part of our field today. Every oncologist should be aware of that, should do tumor sequencing, interpret well the result, and hopefully we'll have the innovative agent available for this patient. But anyway, this is his current strategy in breast cancer, current strategy in melanoma, current strategy in non-small cell lung cancer, and many other tumor types. So, but it's important to know there are still a lot of limitations. One of the limitations, even if we have first generation drug, we have a resistance still a problem. This is the reason we are developing second generation innovative agent, and even sometimes third generation innovative agent, as in non-small cell lung cancer, for example.
Yeah.
So resistance remains a challenge. Another challenge, the accessibility, the availability of the drug at the good time for the patient.
Yeah. Well, access to care is an issue. It's sort of a double-edged sword. I know that during my career, I have watched with fascination how your specialty has improved dramatically in my professional lifetime. You know, this stuff wasn't discussed when I was at medical school, and I'm not that old. But also as a surgeon, I was interested to note your article from 2023, surgery of the primary tumor in patients with de novo metastatic breast cancer, a nationwide population-based retrospective cohort in Belgium. Can you educate those for those folks who didn't have a chance to review
Yeah,
the paper?
I think this is not a new question. It's an open question since years and years and years, but become important question today because we have very good systemic therapy in metastatic setting, in hormone receptor positive HER2 amplified tumor, as well triple negative. It's not so longer negative now, the triple negative, with the development of immunotherapy, development of ADCs, antibody-drug conjugate. So if we have the novo metastatic breast cancer, which is still around 3 to 5% in our population, as the patient responded well to systemic therapy, what to do with the primary tumor? To be honest, there are a lot of studies done so far, but even in 2024, we cannot, let's say, conclude. There are some positive trials, some negative trials, but the design of this trial is difficult to interpret, to compare the studies, and so on. So there are no firm answer to this question. What to do to the primary tumor when the patient responding well to systemic therapy in patient with de novo metastatic breast cancer? Because as we have now first-line therapy, which gave up to 60% objective response rate, sometimes the tumor disappears on the breast. So I think if the patient responded really, really well with the persistent tumor in the breast, I am in favor to consider operating the remaining lesion on the breast, and that's all. But if the patient is not responding well to first-line systemic therapy, I think operating the primary tumor will not change the overall survival of the patient and even the progression-free survival. I think the only exception for that, removing the tumor, improve the quality of life of the patient. If there are some ulceration, infiltration of the skin, sometimes operating, even if we are not improving survival, we can improve the quality of life of the patient.
Yeah, very much so. And just to go back to the point I made before about access, it is a double-edged sword. You know, you've made so much progress in your specialty, but these treatments are not inexpensive. And
And this is a one-shot approach.
yeah, as a society, we've got to make some important decisions about how we deal with this. I was also interested from last year, you co-authored a paper entitled Optimal Use of Granulocyte Colony Stimulating Factor Prophylaxis to Improve Survival in Cancer Patients Receiving Treatment, an Expert View. For those not in the know, I mean, I always prepare for these interviews. This is not my specialty, and I try to be as well educated as possible. But can you please give us an overview, that expert view?
You know, one of the major problem of chemotherapy was the hematological toxicity, and particularly true for the white blood cell. Of course, this is with major consequence for the patient. That means when we have neutropenia, there are a major risk of febrile neutropenia, sepsis, and even death. And so, fortunately, the development of a granulocyte colony stimulating factor, a supportive measure, as a preventive agent, changed completely this problem. And so, reduce the risk of death, reduce the risk of hospitalization for neutropenia-related event, reduce the risk to prescribe antibiotics. So it was really a major supportive measure to prevent this problem. And even, it's important to keep in mind GCSF is not avoiding the nadir of chemotherapy, but the nadir will be less deeper and the recovery will be much more quicker. And consequently, the risk of neutropenia-related event is very low. So classically, we have three categories of patients. Patient with very low risk to develop neutropenia-related event, and normally no GCSF for this patient. A group at high risk, theoretically more than 20% risk to develop neutropenia-related event, and there are really major indication to use GCSF as a preventive measure. And we have the intermediate situation between 10 and 20%. And 10, this is intermediate risk. And there we should add other parameter to consider yes or not to use GCSF as a prophylactic measure. For example, extensive bone met, which there we have the fabrication of white blood cell. Elderly patient, for example, more than 65 years old. So we need other factor to add to this risk between 10 and 20% to consider GCSF. And by doing so, I think this is really a major, let's say, advance in the supportive care related to oncology.
Right. Yeah. Thank you for that. So there's other impacts of cancer. You've obviously said there's the hematological toxicity. Other impacts of cancer and cancer treatment merit attention. Recently, you published an article entitled "Treating Cancer-Associated Venous Thromboembolism: A Practical Approach." Can you give us a précis of the state of the art with this? Obviously, patients with cancer are at increased risk of thromboembolism anyway. So, yes, talk us through this.
I think also in this topic of supportive care, unfortunately, venous thromboembolism event is frequent in our patient with cancer, particularly metastatic cancer, in patient receiving also chemotherapeutic cytotoxic agent. And so, fortunately, we have, let's say, at the beginning, heparin, after that low weight fractionated heparin. And I think in the major advance now, we have oral drug called DOAC, which could be of interest and studied and investigated in this setting. Of course, like any new approach, there are advantage and benefit from the patient, but from other side, there are some troublesome side effect, like, for example, hemorrhage with this kind of approach. So I think the DOAC are there to treat, let's say, venous thromboembolism event, but also there are a lot of studies now look to use these drugs as preventive agent, but taken, I think, and at one time we should, let's say, look to carefully to the therapeutic index, the benefit from one side and the risk from other side, as we did always with this kind of agent.
Okay, so a sort of a broader question for you. What is at or just over the horizon in oncology in terms of etiology, diagnosis, treatment that has you most excited? What are we, if we were doing this podcast, this conversation a year or two from now, what would you be telling me about?
I think I think classical chemotherapy will remain for some of the agent, but the extreme big part will be replaced by antibody-drug conjugate. Antibody-drug conjugate are more selective chemotherapy. Is to some extent the dream of the oncologist. How to have selective chemotherapeutic agent to the cancer cells and much less to the normal cells. And we are there. I think already we have ADCs, antibody-drug conjugate, and more to be developed in the near future and will be available. But important to keep in mind, we are improving the therapeutic index. We are improving the benefits for the patient, but we are not necessarily, we do not have necessarily less toxicity. The pattern of toxicities is changing. Probably will have less hematological toxicity, less mucositis, but we have, for example, more lung toxicities. We have more ocular toxicity, so we have much more benefit, but the pattern of toxicity changes. Second, I think the story of molecular targeted therapy will continue with the development of several generations tracking the resistance. Third, we have already the checkpoint inhibitor. Hopefully, we'll have a new therapeutic approach targeting the immune system. Now we are in the field of bifunctional molecule antibodies targeting the immune system. So that means from one side we are targeting cancer cells, from other side targeting the immune system, and in order to kill the cell, bifunctional, even three functional. That's, I think, clearly will be evolving, and there are a lot in development. And four, I am very optimistic about the new vaccine. I wasn't in the past, let's say, optimistic about the vaccine. But now with the RNA vaccine, I think we started to see very nice result in lung cancer, in melanoma, and so on. Why is this new vaccine? I am optimistic because are not targeting one neoantigen, two neoantigen, because they are targeting dozens of neoantigen, even hundreds of neoantigen in the same time. And so we know cancer cells is very complex. If we focus on one neoantigen, will not succeed. By doing so, we will have more chance. So new vaccine, I am optimistic about it. And finally, I think radioligand therapy will move more and more in our armamentarium. Already the case in neuroendocrine therapy, neuroendocrine tumor, in thyroid cancer, in prostate cancer. But I am sure that in many other solid tumor, we'll have radioligand therapy. I am sure also that there will be some improvement in surgery. Radiation oncologist is more precise. We are in the de-escalation phase. Example, breast cancer. To irradiate breast cancer in the past, we give it radiation in 7 weeks, now in 2 weeks, and for some patients in 1 week. So there are a lot of improvement in therapies. So we are living very nice time, and there are no reason we'll go, let's say, back. Will be at the opposite. We are moving in the good direction. I think I will finish by this sentence. You know, we need that this innovation, that the patient will benefit from this innovation. That means very quick reimbursement for our patient. Because if this innovation will not arrive to the patient, should not be considered innovation, should be considered invention. And invention and innovation is not the same thing.
Yeah. Invention is the delivery of something new. Innovation is finding new uses or incorporating things into a broader platform. So I'm with you. So my final question to you, sir. Let's imagine you find a magical genie, a djinn, and you have 3 wishes for your area of healthcare, for oncology or for healthcare generally. What might your wishes be?
Vaccine which prevent cancer.
That's an all-encompassing wish. Who could wish for anything more? Wouldn't that be lovely?
Yeah.
Well, I'm afraid that's all we've got time for today, and it just remains for me to thank Professor Ahmad Awada for being with us today, and frankly, for everything you've done and are doing to help patients deal with their cancer diagnosis. Thank you so much, sir.
You're welcome. Thanks for the invitation.
Well, I hope you enjoyed that episode of Onc Now, our bi-weekly podcast. If you did enjoy it, please consider subscribing on Apple Podcasts or Spotify or wherever you get your podcasts so you never miss an episode. And please like us on social media and tell your friends and colleagues. And check out our archives because they're growing. And please join us in 2 weeks for another fascinating episode. Until then, I'm your host, Dr. Jonathan Sakia. Please, everyone, stay safe, stay well, stay curious. Bye for now.